So I will get going as more people join. So my name is Matt Comano. I'm one of the nephrologists at Great Ormond Street, and I'll spend the next sort of 45 minutes to an hour or so talking to you about hypertension, which is a subject that I appreciate I'm very interested in, but many of you may not be. I hope I'll convince you by the end of this talk that it is something really interesting and really important in general paediatrics, and something we probably don't do as well as we could. All right, let's just move that on. So I'll talk a bit about what hypertension is and why it matters. I'll talk about how we should measure blood pressure in children, and a lot of the referrals we get can be discharged fairly quickly once we measure blood pressure in a different way. And then I'll use some clinical cases, all of which are based on cases we've seen here at Great Ormond Street over the last 6 months, to cover some of these topics that I think are most relevant to paediatricians and paediatric nephrologists. So I'll cover blood pressure in hospitalized children and how that's different. I'll cover some of the symptoms and the different causes of hypertension in children. I'll look at the investigation of hypertension in children, and then I'll talk about treatment, both the outpatient treatment and the treatment of severe or malignant hypertension in children, which I think is very relevant to those of you who see the rare case in A&E. And I'll finish by just highlighting some of the guidelines that I find helpful in my clinical practice and some key sort of general practice points. I'd like this to be as interactive as possible, so I'll ask a few questions. If you feel you want to offer some answers on the chat, that would be great, but obviously don't feel obliged. And even if you don't put something on the chat, then just have a think at certain points about what you would do in these situations. So what is hypertension? Well, blood pressure in itself is the force that's exerted by the blood against any...
The topic is hypertension.
Oh,
See,
someone's
adults,
talking.
140/9.
Oh, could everyone mute their microphones, please? I think it's, yeah, I think that's gone. So the pressure itself is what's exerted against the vessel wall by the blood. And I think there's a key difference that is really important to understand between hypertension in adults and in children. So in adults, hypertension is defined epidemiologically based on the risk of an adverse event, such as a stroke or a heart attack. And that's generally accepted as above 140/90 millimeters of mercury. But in children, hypertension is a statistical definition based on the 95th centile for age, height, and gender. Therefore, by definition, 5% of children will be hypertensive. I think it's important to remember that when we look at some of these data, when we consider whether we should treat certain children. The main determinants of blood pressure are sort of listed in this diagram here. As nephrologists, we often think of salt and water because in lots of our patients, those are the main determinants of blood pressure. But there are other mechanisms. So obviously the renin-angiotensin-aldosterone system is significant and again forms a lot of our treatment is based on this. The endothelium itself can be implicated in hypertension and also again affects which treatment choices we use. And then the sympathetic nervous system, which is involved in the short-term regulation of blood pressure, is clearly important, with catecholamines being a big factor there. But even if catecholamines, so for example, in a pheochromocytoma, catecholamines are clearly the main cause of blood pressure, there are other indirect effects that affect the kidney, because blood pressure over longer periods of time, rather than the immediate control by the sympathetic nervous system, is generally controlled by salt and water reabsorption in the kidney. And there's also immune mechanisms that are now coming to light that can also influence blood pressure and which may be relevant to children who are hospitalized for things like inflammatory and immune disorders, which can also have an impact on blood pressure. And I think when we see a child with hypertension, it's worth just having a think about the mechanisms that might be involved, particularly when we think of some of the investigations we do. So why is it important? Well, I mean, you all know this, as blood pressure goes up on a population level, it leads to an increased incidence of many adverse outcomes in adults. Coronary heart disease is demonstrated here, strokes, and many other things. There are estimates that about 1 in 4 adults have a systolic blood pressure above 140 and therefore are hypertensive, and there's a huge global burden of disease. Now, thankfully, as I've already said, in paediatrics, we have a very low event rate. So we can't think about blood pressure just in terms of adverse cardiovascular outcomes. We have to think of it statistically. And the normative data from outpatients is the best marker we have of what a normal blood pressure is for a healthy child. But obviously that comes with a caveat that a number of children will be above that and still may be normal. So how should we measure blood pressure in children? Well, the important things I would mention is, first of all, the cuff size. We emphasize this a lot when we speak to people on the phone because it's remarkable how often you can't find the right cuff, even in our clinics, that you want for a child. Having a cuff that's too small will overestimate the blood pressure. If you think about it, if the cuff doesn't encircle 80 to 100% of the circumference of the arm, you have to inflate the cuff more to actually compress the brachial artery. Therefore, you're going to have a higher pressure in the cuff than the true arterial pressure. Therefore, you're going to overestimate it. So the cuff should really encircle almost 100% of the circumference of the arm. And the important thing to think about there is the bladder of the cuff. So the cuff itself, if you have a feel of it, will have the Velcro part, but it also has a bladder that's not the entire length of the cuff itself. And ideally, we want 2/3 or more of the length of the upper arm from the cuff size. The environment's also really important. The data that we use from the European or the American guidelines is based on very controlled circumstances. So those studies were done with children that were calm, sitting down with the brachial artery roughly at the level of the heart. And if you look at research papers, they'll all declare that their blood pressures are done with the patient sitting for at least 5 minutes in a warm room, comfortable. And in reality, most of our blood pressures in clinical practice aren't done in that way. But we should do what we can to try and replicate that as much as we possibly can. And the location, so we prefer to do the right arm if possible. We avoid leg blood pressures for various reasons, unless you're specifically doing a fall in blood pressure if you're suspecting something like coarctation or mid-aortic syndrome. So generally, if you can do it on the right arm, obviously there'll be situations where that's not possible, but try and avoid leg blood pressures if possible. There's different ways to measure blood pressure. So I've listed the main ways that we use here. So invasive blood pressures are the ones that they generally do in intensive care. The important differences there that measures an end-on pressure through the manometer, whereas when we measure blood pressure in a different method, so oscillometrically or with a cuff, we're measuring the distension of the vessel wall. So it's a slightly different method of measuring blood pressure. And that can be helpful because you can obtain an arterial waveform. It's important just to caveat that central arterial blood pressures, like those you might get in neonates, are typically slightly lower than peripheral ones. Oscillometric measures are the ones that we mainly use. So if you go to a GP practice and have a blood pressure done, that's going to be an oscillometric one done with the automated device such as a Dynamap. And that's the ones that most people will use in A&E and on general wards. We often then, when we get a high oscillometric reading, we'll ask people to do a manual reading because generally these devices read about 6 to 8 millimeters higher than a manual one. And the manual one can either be done by stethoscope using Korokov sounds, which everyone's learnt about at medical school, or we use a Doppler, and we actually do all our blood pressures with Doppler. The only downside to that is you can't obtain a diastolic blood pressure reliably, but it does give you a good indication of a systolic blood pressure, and it's much, much easier to do it in a baby. I'd argue it's impossible to do it properly in a baby without a Doppler device. And then ABPM, so ambulatory blood pressure monitoring, we do that in lots of children. Generally, it's tolerated well above the age of 5 if they're compliant. But I'll add a couple of caveats about that in a minute. So ambulatory blood pressure monitoring is where we apply this device to the non-dominant arm. We generally do that because it's a nuisance if you're trying to write and things and you have the cuff on your dominant arm. The cuff size in itself is just as important as with other blood pressure methods. So if you have a cuff that's not appropriately sized, it will give you just as much error with ambulatory monitoring as it will with a standard clinic blood pressure monitor. And it's useful in certain settings, particularly to identify things like white coat hypertension. So just this morning in clinic, I had a girl who I saw who's had blood pressures around the 140, 150 mark. And then when you do an ambulatory blood pressure monitor, it goes down to very normal levels around 100 to 110. Excuse me about the beeping sound that's going on. I'm hoping it will end in just a second. So I'll go on to cover this through some cases now. So the first case I'm going to talk about is a 15-year-old boy, and these are example cases based on real cases, but to preserve confidentiality, I haven't included the actual details of the patient, and I've changed some of the key features. So this boy was admitted for spinal surgery to one of our wards for scoliosis, and he's seen day 4 post-op. He's not been drinking very much, so IV fluids were started, but he's drinking a bit more now. And he's complaining of persistent pain and he's not really been mobilizing. So these are his bloods. So his serum creatinine is 160, so fairly high. His serum sodium is 129, so a little bit low. his serum potassium is normal, and his hemoglobin is 101. So his blood pressure is 142 systolic, measured oscillometrically, and 136 done manually. So pretty high for a 15-year-old boy. So through the chat, does anyone want to offer any potential causes for his raised blood pressure? So yeah, I'm getting lots here. So I'm getting pain, stress coming through. Brilliant, thank you. Yeah, absolutely. Any others? So I put here pain and anxiety, and then I think if you look at his numbers, would suggest again that he's got a degree of potential fluid overload, which fits with getting intravenous fluids as well as starting to drink. And he also has a degree of acute kidney injury as well. You're presuming it's acute because we don't have a previous creatinine, but the 160 in a patient who's previously fit and well would be considered high. And the sodium being low and the hemoglobin being a little bit low would suggest again that he's slightly intravascularly fluid overloaded. So all of these factors could be potential causes for the raised blood pressure. So what should we do about his blood pressure? Should we treat him? Any suggestions on the chat? So some people have said analgesia, yeah, pain control, treat the cause. Absolutely, that's absolutely right. That's exactly what I'd do. So I'd, if you think the cause is a bit of intravascular fluid overload, then you'd reduce his fluid input, manage his acute kidney injury, and that requires some follow-up. But absolutely, if he's in pain, then you should manage that and try and get that down. And I absolutely wouldn't, for a patient like this, start him on a long-term antihypertensive agent, because there's more than enough reasons for a blood pressure that actually, frankly, isn't that high at 136. So if there's one paper that you read as a result of this talk, apart from the guidelines, I'd really encourage you to have a look at this. It's a review that was published last year looking at the evaluation of blood pressure in hospitalized children. I think this is really important because a lot of the phone calls we get are about high blood pressures in children who are in hospital. And one of the tables in this review is pictured here. It basically shows the 2017 American guidelines for hypertension, and that you can see in the left-hand column with the 95th centiles, and then you have the pediatric ITU population here on the right. And you can see here that a 95th centile for a 15-year-old in ITU is over 150 millimeters of mercury. And so that just shows you what an impact being critically unwell, having factors such as pain, can do to your blood pressure. And I think it's important to remember that when we're looking at whether we treat these children. I would suggest that you let them get better and improve all of these other factors that we've talked about before starting any long-term antihypertensive treatment. So just to summarize that, so we've talked about a number of the reasons why children in hospital might be hypertensive or have blood pressures that are raised: pain, anxiety, fluids, other medications. Their blood pressure measurement might be less rigorous in admitted patients, so they might have blood pressures done in the supine position. Ideally, we should do them in the sitting position. They might have them done with leg cuffs. And important to remember that the normative data we have is derived from the outpatient setting. Therefore, it's not directly applicable to hospitalized children. And I think it's also important to remember that whilst invasive blood pressure is clearly the best way to monitor blood pressure in the ITU setting, particularly when you're looking at rapid changes on a minute-by-minute basis, but that can also be prone to error. It's not always the gold standard. So for those of you who do work in ITU, it's always important to just compare those invasive blood pressures with a non-invasive one at least every 4 hours, just to make sure that the readings aren't particularly spurious and we don't need a recalibration of the device. And I would really emphasize that most inpatients who have slightly elevated blood pressure, who have some of these other factors to explain it, such as pain, fluids, anxiety, don't need acute treatment for the blood pressure unless it's really very raised, or unless they're symptomatic, or unless there are any other factors such as the actual treatment of the cause itself. So I wouldn't advocate starting a long-term antihypertensive therapy until we've allowed them to resolve their issues such as pain, and then we can think about doing that. So I'll move on to the second case now. So this is an 11-year-old boy. He has had increasing anxiety and abdominal pain in the last year, and he was found to have an abdominal mass when he presented to A&E. His blood pressure was found to be 170 over 94, and that was reproduced on multiple readings. And some additional symptoms he had included nausea and excess sweating. Now, this is clearly going to be a relatively rare case. Any ideas about the differential diagnosis here? Anyone on the chat? So yeah, I've got a pheochromocytoma, yeah. So that's absolutely in the differentials. Yeah, lots of people saying that. Wilms tumor, absolutely. Good. So these are not common cases, but I think they demonstrate a number of important points, and these are the cases that we clearly don't want to miss. So pheochromocytoma or paraganglioma, they're clearly at the top of the list. Neuroblastoma, Wilms tumor, adrenocortical tumors even rarer, but any mass that causes a renovascular compression can also cause quite high blood pressures. And clearly with the mass here, he needs that investigating urgently. So these are some images demonstrating what the mass might look like. Ooh, sorry about that. So here's his axial imaging, and here he's got an MIBG scan, so you can shows the big uptake, and his plasma norepinephrine is above 39, so very markedly raised. So clearly we have the diagnosis here. So in this case, because of the position, it was considered to be a likely paraganglioma. So what management steps should we take next? That's a difficult question. I wouldn't expect people to know the details of this, but does anyone know the principles of managing a case like this? It's one of the only times we have to be quite careful about which agents you use. So generally, with cases like this, so yeah, we've got one coming up, so alpha blocker first, absolutely, A before B. That's absolutely right. So we start with alpha blockade, and that's because if you start with beta blockade first, you can actually block some of the beta-2 mediated vasodilation, and therefore you get unopposed alpha mediated vasoconstriction. So if you use a beta blocker before an alpha blocker, you can actually make the blood pressure worse, and you can really make them spike up. So it's just important, if it's a case like this, you're probably better off not doing anything, certainly better off not doing anything than starting a beta blocker. So we start with an alpha blocker, typically phenoxybenzamine, and then we might use a beta blocker if we need to. We carefully prepare them for surgery, often they're on our ward for a few weeks beforehand. And ideally, we want them to be symptomatic from the alpha blockade, so you really need to block them quite hard. And these children also need quite a lot of salt and fluid. So sometimes we send them home for a period of time and just tell them to eat and drink lots and eat lots of salt to try and expand their intravascular volume, because when you ligate the vein for these tumors and take them out, they can then really plummet their blood pressure, which is obviously something we want to avoid as well. But that case is a rare one, but what I want to use it is to just demonstrate some of the symptoms of hypertension that you might get. So what do people think is the most common symptom of hypertension that we see? Any ideas in the chat? What's the most common symptom that we see? So I've got lots of headache. It's a bit of a trick question, really. Headaches are coming up quite commonly. Yeah, interesting. So the most common symptom is nothing. Yeah, so a few people have got that. So we just find it incidentally. By far and wide, that's how we detect hypertension, and most of our referrals are incidental findings when it's measured. But there are clearly some symptoms. Any others in children or adolescents? I've separated these two out because they can present quite differently. We've got headaches. Any others that people know about? So in children and adolescents, we tend to say we've got, yeah, nosebleeds, blurry vision. So visual disturbance, we can see facial nerves palsy. So it's always important when you get a patient coming in with the bells to check a blood pressure. It's very rare to get a cerebrovascular event or seizures. We do see hypertensive encephalopathy in our dialysis patients who might acutely have big swings in their blood pressure. And sometimes more in infants, we see congestive cardiac failure as an actual presenting feature of hypertension. And epistaxis is obviously one of them we also see. In infants, it tends to be a lot more difficult to know that a child is hypertensive, and that's coupled with the fact that it's really difficult to measure blood pressure in these children. But some of the infants we've seen who've come in markedly hypertensive with things like renovascular hypertension have presented with poor feeding, irritability, and often they'll be investigated for things like sepsis beforehand, because on the balance of probability, that's by far much more common than something like severe hypertension. And they often present in cardiogenic shock as well. And in terms of the causes of hypertension in children, you'll see lots and lots of tables like this in various different texts. The key thing I think to think about was roughly what age is the child, because you have quite different causes across the different age groups. And you can find this, I think this is actually lifted from the Nottingham guideline, but you can find this in most of the texts. And certainly if you look at the European guideline, that has a similar table to this. So I'll move on to the third case now. So this is a 16-year-old girl. She was referred to the hypertension clinic from an obesity service and referred for a 24-hour ambulatory blood pressure monitor. They'd already done a lot of the investigations there. She has a BMI of 38, so that's pretty high. She has a strong family history of hypertension and cardiovascular disease, and she eats a lot of takeaways. Her blood pressure was 152, so certainly elevated even for a 16-year-old girl, and that was measured with a thigh cuff. So in really obese patients, it's important to try and measure with an adult, it's called an alternative or a thigh cuff, because sometimes even the large adult cuff will be less than 80% of the circumference of their arm. And again, just to mention that in the European guidelines, which we should generally be using for our centile data, above 16, they generally follow the adult numbers. So above 140 over 90 would be considered hypertensive, but she's clearly hypertensive here. So just as a bit of an aside, many of you may recognize takeaway meals such as this, and I just wonder if anyone has any ideas how much salt is in this meal. Because we've got 40 grams, that's quite a lot. The recommended daily intake, it's got 4 grams, 10 grams. Okay, someone's heard me talk before. So I mentioned this in all my hypertension talks because for me it was a really sort of stark realization when I discovered this, how much salt is in some of these meals. So the recommended daily intake is about 6 grams of salt. If you think about that in sodium, that's actually less than that. It's about 2 point something of sodium, but we probably need significantly less than this in reality. So this has 9.9 grams of salt in it, as you can see here from this screenshot from their nutritional information, which is 165% of your recommended daily intake. And if you're having this at lunchtime, as well as having a takeaway in the evening, you can very quickly see how much salt people are consuming in these takeaway meals, and it's really quite alarming. And I've often thought, how does salt contribute to hypertension? It's not entirely straightforward, and there's not the body itself clearly can't be thought of in this way. But if you just think about it simply, 1 gram of salt is about 17 millimoles of sodium. So this meal gives you 170 millimoles of sodium. And the most adults will have about 3 liters of plasma in their circulating blood volume. So then in their circulating blood volume, they'll have about 420 millimoles of sodium if their plasma sodium is normal. If you immediately add that 170 millimoles of sodium, which obviously is an artificial situation because you can't just inject it into the intravascular compartment, you'd require an extra 1.2 liters. So that's 40% expansion of your plasma volume to keep your serum sodium at 140. So that just demonstrates to you, I think, how significantly this can affect blood pressure in just one meal. And it's why you feel so thirsty after you eat one of these. But if you think about sick children, when you give them the fluid bolus, if you gave a sick person a fluid bolus, someone who's hypotensive, more than a litre of fluid, you would generally see a response to that. So I think that just demonstrates to me how important it is to emphasize a low salt diet to some of these patients. So she's previously had, as I said, multiple investigations for her hypertension. All of them have come back normal, and that's often the case in these patients. And if she was 16 and referred to a GP, she may not have anywhere near the number of investigations we would do in pediatrics. So just have a think about what investigations you would have done in this case, and have a think about what your differential diagnosis may be and how we should treat her. So yeah, I've got some suggestions coming here. Screen for metabolic syndrome, so diabetes, lipids, absolutely. Renal ultrasound, thyroid function tests. Yeah, so lots of different texts will have relatively similar lists of investigations for you. I want to sort of just expand on that slightly. So when we think about how to investigate hypertension in children, we have to think about what's common and what's uncommon. And lots of us as paediatricians will say, oh, well, they need to have this full list of investigations, including the plasma metanephrines. Based on the data I showed you earlier and the normative data, 5% of children will be defined as hypertensive based on the normal distribution. The annual incidence of PHOs in the USA from a paper was around 1 in 10 million. So that means we may get just over one case a year in the whole United Kingdom of pheochromocytoma. So whilst I'm not suggesting that we shouldn't do things like plasma metanephrines, I think it's best to start investigating children with hypertension based on your history and examination on where you're likely to get most of your significant results from. And if you do that in a stepwise way, and you find actually this child's only very mildly hypertensive and doesn't have any risk factors based on their history or examination, you can potentially save yourself doing some of the more expensive investigations. It's also worth remembering that some of these tests, when you do them, and as I say, a 16-year-old who sees their GP with hypertension will absolutely not have plasma metanephrine sent as a routine test. But when you have a very rare condition, whilst the specificity of a test might be quite good, the positive predictive value may actually be quite low purely because it's such a rare condition. So more often than not, we'll get referrals with very mildly elevated things like urinary catecholamines or plasma metanephrines. And actually then we'll go through a cycle of repeated testing because they're very mildly elevated and we want to see a normal value, when actually we should just get on and treat the hypertension. So this is the list that I generally use in my practice. Start with simple things: urinalysis, full blood count, renal function. Random cortisol and thyroid function tests are helpful. Generally, it's good to do the renin and aldosterone, ideally before you start treatment. And when we do a renal ultrasound, we'll always ask for it to be done with Dopplers. Dopplers will help us identify if there's a renovascular effect, and that can obviously give us a clue, and then we know what the diagnosis is. These other three in purple that I've put here are clearly important to do. Certainly if you have a patient presenting with severe hypertension and with typical symptoms of a secretory tumour, you should do them. And in some patients where you haven't found a cause through other investigations, it's absolutely the right thing to do them. But often they'll take quite a long time to get back. And I'd argue if you have a mild case of hypertension, certainly in an inpatient who's in pain, as we talked about before, you don't have to do these straight away. So that's the only caveat I'd add there. And also we want to look at other risk factors, so things like, as people have said here in the chat, metabolic syndrome, so fasting lipids, blood glucose, and we also look for target organ damage. So the urine albumin creatinine ratio looks to see if there's been hypertensive damage in the kidneys, although that could also be due to the primary renal cause, so it's important to separate those two out. And we would also generally do an echocardiogram and an ophthalmology review. The echo is really helpful, A, to tell you whether there's a cardiac cause, so sometimes we detect a coarctation in our clinics, and also to look at whether there's left ventricular hypertrophy. If you're unsure whether the patient truly is hypertensive, and then you find they've got left ventricular hypertrophy, that's a big pointer to the fact that they've potentially had long-standing hypertension. And then second line investigations we do based again on the history of the examination and if there's something pointing us in that direction. In teenagers, it's important to think about some of these other things. So toxicology screen, really important to think about pregnancy in an adolescent female, because that can clearly cause hypertension. I think about 5% of women have preeclampsia, so that's a really important thing to not miss. Urine steroid profiles, if you're looking at sort of some of these rarer causes, genetics. A DMSA we would generally do as well, particularly if we think that there's an intrinsic renal cause. And then eventually we might go on to have formal interventional radiology involvement and do things like angiograms, particularly if we find that the Dopplers on the ultrasound are abnormal. But as I said before, I think these are tests that we should do in a stepwise manner. And once the others have not revealed what we want, and if we still have a significant case of hypertension, we'll go on to do these. So I'll move on to the last couple of cases now that go through some treatment for hypertension. So case 4 is a 9-year-old girl. She's born in Romania and came to the UK a couple of years ago. The GP's referred her. She's had 3 febrile UTIs in the last year, and you find that her blood pressure is 132 in outpatients. Now, for a 9-year-old girl, the 95th centile blood pressure is probably going to be somewhere around the 120-ish mark, and obviously you'd look that up on tables based on her height. So that's clearly high. Her parents are relatively poor historians, but they tell you that she's had lots of febrile illnesses in childhood, often requiring hospital admission and IV antibiotics, and that may make you suspect the fact that she's had UTIs throughout childhood. So if you did a DMSA scan on her, what might you expect to see? Any ideas? Yeah, so lots of people saying scarring. So yeah, so this is a case where we would absolutely do DMSA at the start of our investigations. And you see here that she's got some scarring. So you repeat her blood pressures a number of times, and you're generally finding readings that are above 125 to 140. So she's confirmed as hypertensive. What first-line drug do you think we could use? So let's say we've made the decision that we want to control her hypertension. Any ideas about what the first-line drug might be for us? So I've got ACE here, so ACE inhibitors, yeah. So you've got lots of different options. I've put some here. I think so looking at what people are saying, so amlodipine, yeah. So amlodipine is definitely the most common drug we will start. It's a very safe drug. We use it a lot, and we have a lot of experience in it, and it's very difficult to cause harm with it. It's got a relatively smooth profile over 24 hours, so you're not going to rapidly drop the blood pressure. If you've got chronic kidney disease, which some patients like her will have, I haven't given you any figures on that, then certainly an ACE inhibitor, particularly if she's got proteinuria, would be a good option, or losartan as an angiotensin receptor blocker. Sometimes we use atenolol. It probably wouldn't be our first line in this case. Diuretics rarely, so furosemide I wouldn't use in a long-term case like this. And thiazides as well we use less often, but in certain situations they may be helpful. So in terms of treatment in the outpatient setting, why are we treating hypertension in children? Well, what we're trying to do, if it's not acute and severe, is we're trying to prevent long-term complications. And as I've said already, thankfully, the event rate in children is low. And therefore, I'd say that there isn't a particular rush to start treatment in a case like this, where although her blood pressure is certainly raised, you know, it's not a case where I'd say to her, you have to wait and get the medication from pharmacy. If there's a 4-hour wait, you can get it from your GP next week, and that will cause absolutely no harm. Because this is a very long-term effect over months, years, and even decades in terms of the accumulation of cardiovascular risk. And although in this girl we've got a clear cause with renal scarring, and if she has proteinuria or chronic kidney disease, we probably would start an ACE inhibitor. In many other children and young people, the European guidelines would now support a much more conservative approach. So I would start, and certainly with the obese girl I mentioned previously, I'd start with conservative measures. So clearly alcohol and smoking are less relevant in some of our children, but important to mention to adolescents, and particularly those with multiple risk factors. But the salt is a really important factor. Lots of our children will be in families where they're eating a very high salt diet, lots of processed foods, and that's something they can easily modify. We've seen from before how high some of the salt content is of some of this food. We'd encourage those with a high BMI to do more exercise, to try and limit their weight gain, try and reduce their weight through dietary intervention. And that would be my first choice in many of these patients, rather than going down the pharmacological route. In terms of what we target, we often target the 50th centile in our renal patients, particularly if there's proteinuria. But as you can see here, I think this is from the European guideline on the right. And if you've got hypertension and you haven't got you know, any organ damage and you haven't got a symptomatic or secondary cause, then you can very justifiably go down the non-pharmacological route initially. And then if you're failing to have any effect there, then you can start thinking about going on along the pharmacological route. But I think it's important to bear in mind that once we start treatment for hypertension, unless it was started inappropriately or there was a transient cause to something like HSP or post-strep glomerulonephritis, where we know there's likely to be resolution, you're kind of committing these patients to very long-term therapy. And that's why I think we should always try to go slowly with these and start with conservative measures first, which will also have lots of other health benefits that we all know about for these patients. So again, from the European guidelines, I think you've probably seen charts like this before. The adults use them, looking at which different combinations we try to use. And we wouldn't generally use an ACE inhibitor and an angiotensin receptor blocker together in children. That's not been found to be a good thing to do. But there are lots of sensible combinations here in green. And I think when you're starting treatment, when you're starting multiple drugs, most people would refer those cases to either one of the spin nephrologists in one of the pediatric centres or a pediatric nephrology centre. I would use drugs in a sensible way. So if you have a patient who started on amlodipine and you want to start a second agent, it may not be a good idea to use an additional vasodilator because that may make them quite tachycardic. So often we'll have the patient on amlodipine and then we'll start them on a beta blocker as a second line agent. So it's just important to think about the different mechanisms that you use. And there is some evidence base here for the ones in green that are connected and the one in red that we try to avoid. The European guidelines, again, this is a table from it, and will tell you some of the cases where the treatment of hypertension can be guided by the underlying pathology. So as I've already mentioned, in a patient who's got chronic kidney disease, particularly if they've got proteinuria, we'd often use an ACE inhibitor or an angiotensin receptor blocker. If you've got an acute case of hypertension in something like a post-streptococcal glomerulonephritis, and you've got fluid and water overload and salt overload, then something like furosemide is a perfectly appropriate short-term option. It will deal with the hypertension by dealing with the actual cause. So when you think about the cause of the hypertension, which isn't always known, that can help you decide which medication to use. So the last case I'm going to talk about is one that just talks about the acute management of hypertension and particularly malignant or severe hypertension. I think we're not meant to call it malignant anymore. So a hypertensive emergency. So this was a phone call I got when I was last on call a few weeks ago, and this was from another country. The boy was a 7-year-old boy who had presented to paediatric A&E with hematemesis. He'd had some preceding headaches and vomiting over the last few weeks, but he was clinically quite well in the A&E department despite having this hematemesis. But when I talked to mum when they arrived, you hear her actually saying that in A&E, because what was interesting is his hypertension wasn't detected until he got to the paediatric ward. And in A&E, they measured his blood pressure multiple times, but they felt that the machine was broken, and they weren't actually able to get one with a stethoscope. And when you see his blood pressure, you'll know why. So he was then admitted to the general paediatric ward for some observation because of the hematemesis, and I think he was awaiting blood tests at that point. And then when they measured it on the ward, they actually found it to be 220 to 240, so really quite high, and that was confirmed manually. And the reason they weren't able to get it manually in A&E, we presume, is because they weren't inflating the cuff high enough. Because if you only inflate it to 170, you're not going to obliterate the artery if the pressure's higher than that. And in most cases, why would you inflate it above 150, 160 if you're not expecting something like this? So he was then transferred to their intensive care unit and started on labetalol infusion, and his blood pressure was steadily improving to about 170, 180 over the next few days. So some relevant investigations here. So his serum creatinine was 28, and his serum potassium was 2.9. His echocardiogram showed moderate left ventricular hypertrophy. Anyone want to suggest some differential diagnoses? And any further investigation results you'd like to know about? Just wait for a second on the chat there. So I've got hyperaldosteronism here, consumer, absolutely. So it's important. I've given you the potassium for that reason. So what that potassium tells you is you've got, as you've said, the fingerprint of aldosterone, which suggests that there's RAS overactivity. That can be from a number of causes, Conn syndrome being one of them. So central cause, yeah, absolutely, really important. In any case like this where you've got severe hypertension, always have a think about the brain, and if there's any clinical features that might suggest it, a CT head's really important. If you think about adults who have strokes, or children, but adults you see it much more commonly, they will often be hypertensive, and that will be tolerated to maintain their cerebral perfusion pressure. So this boy actually had a different cause that we see quite a lot at Great Ormond Street, but it's relatively uncommon overall, but is typically misdiagnosed in this way because the blood pressures are so high that people don't actually measure them. They just assume that the machine is broken and then don't repeat it. So this boy had an ultrasound of his abdomen, and that was reported as structurally normal, actually, with no obstruction, normal looking kidneys, and normal Dopplers actually. But then he had a CT angio when the nephrologists over there saw him, and that suggested he had some tortuous renal vessels with beading. And then he was transferred to us for interventional radiology input and management of his blood pressure. So that's a picture of what his angiogram might look like. So you can see lots of renovascular disease here. The beading of the renal arteries bilaterally is something that we see a few cases of a year here, but can obviously cause quite marked hypertension, as in this case. Now, what do people think is the main priority in managing his blood pressure? What's the main aspect to managing this that you think I'd like to emphasize today? Any ideas in the chat? How should we reduce his blood pressure? Yeah, perfect. So we've got bring it down slowly, slowly, absolutely. So that's the key message, I think, from today's talk for me, is if you have a patient like this in A&E and resus, don't drop it quickly, and lots of people are saying that, which is great. Slowly on infusion, absolutely, and avoid ACE. Interesting, yeah. So one of the questions from the other nephrology centre about this patient was, should they start an ACE inhibitor because they weren't able to bring his blood pressure lower than 170 to 180 on maximal labetalol. And two things to that. So if you have bilateral disease and use an ACE inhibitor, you will absolutely drop his blood pressure, but you may also impair the kidney function to the point where he gets a degree of irreversible kidney injury. So I wouldn't do that in this case. It's sometimes an ACE inhibitor is the only thing that will bring the blood pressure down, but certainly not in a case like this, and not acutely. Because with an ACE, you can reduce the glomerular perfusion pressure to such an extent that they basically shut down their kidneys. So the management of severe or hypertensive emergency in children, really I'd emphasize it slowly. And the other thing I'd say is, in that case before, when they had the blood pressure at 170 to 180, my advice was to keep it roughly there. I wouldn't drop it much lower. If he's been sitting at 220 to 240 in the community for weeks or months, or even years potentially, given his underlying pathology, you absolutely don't want to bring that down too quickly. And the reason for that is you can get some really unpleasant complications. So watershed infarcts are seen here. So you see infarcts in the brain at points where there's a bit of a watershed between the cerebral artery areas, and you get an acute ischemic optic neuropathy. So you can have it's a painless cause of blindness. And sadly, we see this in some of our children on dialysis who very acutely drop their blood pressure and can go blind from this. So it's really important not to drop this blood pressure too quickly. His echocardiogram suggests that he's got left ventricular hypertrophy, therefore he's clearly had this as a long-standing issue. Different texts will tell you different things. Some say bring so this is, I think, from the Nottingham guideline, which I think is very clear about how it manages acute hypertension. And it would suggest bringing down the blood pressure over sort of 48 hours. And you would generally want it to be done with an IV agent because you can titrate it much more easily. And the important thing is to have 2 lines of IV access so that you can give fluid boluses if you drop the blood pressure too quickly. So short-acting IV agents are the best thing to do in this case. The caveat here at the top, I'd emphasize again, if you're suspecting intracerebral pathology, make sure that's investigated fully. And CATs will often suggest that if you speak to them in London about an acute case like this. And in terms of which drugs we'd use, most of this would be done in intensive care or in a renal unit. I would use the drugs that your nurses are most familiar with because that will be the safest option. There's no good evidence between them, but generally we would start with labetalol and you might go on to nitroprusside. I absolutely wouldn't give agents such as nifedipine or hydralazine, so it's short-acting agents, because they could really drop this blood pressure too quickly. And the important thing then is to think about what your underlying cause is and then go on to treat that cause carefully. So I've come to the end of the things I wanted to say today. I'll just finish with a few of the sort of key points that I'd like people to remember if possible from this talk, and the things I think are most important in general in general pediatrics and in our practice as well. Firstly, it's to measure the blood pressure as accurately as you can. If you can do manual blood pressures, that's better, with a correctly sized cuff. And just think about the many reasons why a blood pressure may be raised in a pediatric inpatient: pain, anxiety, IV fluids, medications, for example, and try and treat those. As everyone said in the chat, that's the best way to treat hypertension in these patients. Most children with hypertension are asymptomatic, and we detect them incidentally, or they come into hospital for something else and we find that their blood pressure is high. And really important to remember the impact of a high salt diet in our sort of population, because that's clearly a modifiable risk factor, and one we can do without any kind of medical intervention. My view is that investigation should be done in a stepwise manner, and we start with the first line investigations based on what's most likely from the history and examination, and then work up and do the more complicated and expensive ones if there's no resolution or if there's a very severe case of hypertension. And generally, we would want conservative measures to be our first line outpatient treatment for hypertension. And as I've just said, if you've got a severe case of hypertension or a hypertensive emergency, the key thing is to reduce the blood pressure slowly. The safest thing, if you're unsure, is probably not to reduce it at all, and just phone a friend and speak to someone, because these are super rare cases, and they can be pretty tricky to manage. I'll finish with a few suggestions for reading. The European guidelines that are here from 2016 are the ones I use. I think that the document's fantastic. It has lots and lots of detail, has lots of doses and things that we can use. A couple of UK colleagues are on that guideline, so I think it's reflective of what we would do in this country. And then these two papers. So I haven't really talked about neonatal hypertension. It's a bit of a separate topic, and lots of different things to think about. But if you have a look at this paper on neonatal hypertension at the bottom, it gives you a good overview of that. And then this paper that I've mentioned about blood pressure in hospitalised children as well, I find a really useful read. Thank you very much for listening. I'm very happy to take any questions on the chat if people want to hang around for a few minutes. And I hope you enjoy the rest of this renal week on the London School programme. Okay, so we've got a question. Thank you to those of you who left positive comments. So if a patient is asymptomatic, at what blood pressure level would you consider it malignant or severe, warranting IV medication? I think that's, if they're asymptomatic, that's pretty reassuring. That's the first thing that I would say, is I wouldn't do things quickly if they're asymptomatic. Generally, 99th centile plus 5 millimeters of mercury is what you would consider as stage 2 hypertension from the guidelines. So that could be one marker. But I think in terms of IV therapy, if they're asymptomatic and if it's not above the sort of 170, 180 mark, you don't need to do IV therapy. If they're asymptomatic, you're probably in a position where you can do some investigations and sit tight with them, because they've either had it for a long time, or we've got an issue of spurious readings. So I wouldn't do IV therapy if they're asymptomatic and it's not, let's say, above 170, 180. Got a few more. So the response to the initial slides, I would, if you have a look on the YouTube channel, you should be able to see them all there. So a question here about A&E. So not many EDs do blood pressure. Do you think in the ED setting, all patients should have a blood pressure, or in the context of being acutely unwell, does it make it harder to interpret? Well, this is a, I mean, from a nephrology point of view, we would say we would always want a blood pressure done. And we have had some of the renovascular cases come to us, having been to the hospital a few times and not had a blood pressure done, and therefore not detected. So you will definitely detect more. The worry is that you'll over-detect some patients that aren't really hypertensive for the reasons that have been mentioned here. I think there is no national stance on this, but I think if you can do a blood pressure in every clinic patient, that will probably be a more valid measure, because you're more likely to get readings that can be compared to the normative data rather than in patients in A&E. So I've got a question here. If the patient's discovered that he has a high blood pressure on a regular checkup and is asymptomatic, should I treat until all investigations are done? I think similar to the first one, if they're asymptomatic, I would say there's no rush to treat unless the blood pressure is really very high, and in which case you'll probably be phoning a subspecialty team anyway. If their blood pressure is, certainly if it's in the sort of just above the 95th centile, around the 99th, then I would start with all the investigations, because you may well find a cause that you can treat, and also it gives you a bit of time to ask them to do some conservative measures. Would you consider treatment for white coat hypertension in certain children? No, I wouldn't do that. I wouldn't do that. If you confirm it by doing an ambulatory blood pressure monitor and their blood pressure profile is normal and they have normal nocturnal dipping, then there's no benefit in treating a white coat hypertension, because again, it comes back to that point about what's the purpose of treatment. It's to reduce your long-term cardiovascular risk, and if you've got white coat hypertension where the blood pressure goes up for very short periods of time, then I wouldn't treat that. Is there a preferred antihypertensive to use for patients hypertensive as a result of long-term steroids? Well, so steroid use causes hypertension in a number of different ways. So you do get salt and water retention with that. So from a mechanistic point of view, you could think about using a diuretic. Generally, in most of these patients, and the ones that we probably see the most are the ones, so often patients who have steroids for things like infantile spasms will come to us and be hypertensive. It depends a bit on how long they're likely to be on high-dose steroids, but most patients would be tapered off. So a drug like amlodipine, a simple vasodilator, would be a perfectly reasonable option in these patients. And amlodipine is probably the one we use the most often in these patients. Good. I think most of the questions are finishing. People seem to be logging off. I'd encourage you to come to some of the other talks we have this week. I think there'll be some really interesting ones. And thank you very much as well to everyone for engaging with the London School programme. I'll stay on for a minute or two if there are any other questions, but thank you to everyone who's commenting.